Good evening. My name's Stevie Perks, and I'll be presenting this evening on my experience with factors that contribute to suboptimal dosing in OPAT, and I'll specifically go into the second half of this presentation about my interpretation of the current state of the age-old question of can we use Meropenem in OPAT. My declarations, so I have received some grant monies from Baxter and the Townsville Hospital for my OPAT research in the past. So tonight I'll basically be going through how I question what things I think of when I'm going through the evidence, my evaluation of standards that we use, and discussing gaps in standards. I'll then go through a peppering of studies that relate to Meropenem, and then I'll, summarize with where I think we currently stand with Meropenem in OPAT. Okay, so let's start from the beginning. What do I actually think about when we're questioning evidence for medications for OPAT? So the first part is the planned dose from the clinician actually being completely delivered to the patient? And then the second part is what's the clinical manifestation of that total dose actually being delivered? So did we actually clear the infection? Did we treat the patient appropriately? Now, the way I break it down, and this is how I assess the evidence into different stages of the OPAT dosing, is when we're thinking about is the total planned dose being delivered, we've got chemical stability issues and then physical issues that affect the flow rate. On the chemical stability side, we're looking at is there less active pharmaceutical ingredient actually in the solution by the end of the infusion, because that results in less drug. But also as a side thing, there's also the buildup of possible degradants that may cause harm or may cause issues. From the physical effector side, are there any factors that potentially slow down the delivery rate and thus equate to less fluid being delivered, thus as a ratio of drug in fluid, you get less dose being delivered. So both of those factors together combine to tell us what is the total dose that actually ended up getting into the patient from the beginning point of what the OPAT planned dose was. Now, from the dose being delivered, we ask ourselves, what's the effects? So what's the clinical manifestation? So does it maintain time above the MIC throughout the course of these infusions? That's what we're wanting to know. And I guess the finality of all of this is, and I guess possibly the most important part is, what's the actual clinical outcomes then for the patient? Did the treatment work? So when I'm looking at papers and evidence, I ask myself, at what stage is this paper designed at? Is it a stage 1 technical study looking purely at chemical stability, or are we looking at actual clinical outcomes, which is, I guess, the most important factor of all of this? So if we look at the Australian standard specifically, and I'll break this down, and you can do this with any standard for around the world, and finding out what is my standard actually saying and what are the gaps in my standard is probably a good place to start. So in the first part, talking about it's got to be sufficiently stable and potentially for extended periods. What it's meaning there is, realistically, we should have stability data that has sequential storage stability, meaning there's a refrigerated period plus the 25 degrees Celsius or higher as the run out phase. And as I guess what we call, the gold dream standard is if we could have 7 days within the fridge, because that allows us for batch ordering week at a time, and then a 24-hour run out at the higher temperatures. That's sort of the gold standard we'd like to have for stability studies. The next part is that we use a defined greater than 90% concentration at the end of the infusion. Now, the drawback with this is, and I've published some papers around this, other methods, is that just means that the last milliliter of infusion going in has greater than 90% concentration within it. But really, there are probably better metrics out there, I believe, such as the total dose administered method or the maximum daily delivered dose, which calculates across the full 24-hour period. So if an infusion broke the 90% threshold at the 23.5-hour mark and dropped just under 90%, that would be deemed unsuitable for use in OPAT. But that infusion may have delivered a 95-96% of the total desired dose over the course of the 24-hour period. So there's some gaps or some possible deficits in guidelines in that sense. The next part is the the evidence, as I said before, needs to be specific with regard to temperature, buffer, fluids, diluents, even vehicles that it's being delivered in, in PVC preparations and things like that. So we need to make sure it's as specific to OPAT as possible. They talk about the presence of degradation products may affect shelf life. It doesn't really expand on that, and that's probably one of the biggest gaps in evidence, is that it's not often investigated. So we don't know whether these degradants are harmful for a lot of medications, or the level of antibiotic activity that some of the degradant parts may or may not have. And the last part is this is the only part out of all the parts in the standard that talks about something that's not to do with chemical stability. It just mentions that temperature could affect the flow rate, high and low, making it go faster or slower. It doesn't elaborate hugely on that. And one of the big questions that I get that's not well answered is, can an ice pack really affect the flow rate? And different people have different opinions on that, given that there's a line from the reservoir that should equilibrate to a reasonable temperature, because the flow rate restrictor is actually the part that's attached to the arm. So hopefully it doesn't, but I don't believe it's been well studied. Something that's not in the standards that I'll quickly touch on is the choice of the dose. Now, this is not really relevant to meropenem and the very low dosing antibiotics, but once you go over 12 grams, we start to find that we get incomplete run out with some of the infuser devices, and certainly over 17.28 grams. There's an equation from this paper that's referenced down the bottom where less than 90% of the volume actually gets delivered, and we were finding this off the back of infusers being returned by patients with a little, like a ball bubble of fluid still in them. So in this study, we ran out a bunch of infusers, plotted it all, and you can find that then basically down to there it's fine, but we had up to 15% and almost 15% in the Piptaz 18 gram doses. And the question there is, once again, this is about the dose being delivered, but you ask yourself, what's the clinical manifestation of that? Is it relevant or not? Maybe, maybe not. But once again, this is a piece that's aimed more at the top part of that flow chart I was referring to before. Now, if you start looking specifically into meropenem now, so with the ETG refers that it's got stability data backing its stability for 5 days in the fridge, and then the at elevated temperatures, so at room temperature and at 37 degrees, we've only got 12 or 6 hours. And down the bottom there, you can see that it references that it basically suggests we shouldn't be using it. Consider an alternative antibiotic with better stability. So the ETG is pretty much driving us towards picking other options. It's not stable to be used in OPAT. Okay, so now I'm going to take you down a quick little journey of meropenem's history through the years, and towards the end, a couple of papers that I think are really changing the direction of how we consider meropenem in OPAT. So this here is this is the kind of paper that you would have seen greater than 15 years ago looking at meropenem. They were looking more at a combination of just extended infusions in general, and they were finding the kind of data that you see in the ETG guidelines, stating that you've got, this one says that you've got 10% loss in 8 hours at the higher temperatures, and 8 hours you're losing 6% loss at 20 degrees. So in this kind of study, if you're trying to say, is it applicable to OPAT, it has no run-in refrigerated phase. It's got a very low concentration equivalent as well, if you looked at it at the study. So it wasn't really that suitable, but it sort of set the scene that maybe this is just straight up not suitable for stability for the certainly longer periods of time. There was a systematic review published a couple of years ago, 2019, that showed, I guess, a collation of some of the more the higher end stability studies, and showed that in general we're getting roughly 12 hours for that 25 degree range. And even with this one here, you could see that the doses for most of them are in the suitable range for what you'd possibly be selecting for meropenem dosing. Next, we've got the study by Foyer al. In 2019. Sorry. Now, this one was quite a good study. I did like it because the concentrations that they investigated from 6 milligram per mil to 25 milligram per mil. When you calculate that out, that's the 1.44 to 6 gram dose. So that's a really good dosage range, the kind of dosage you would be expecting to be choosing in OPAT. And they also tested sequential storage. So they did refrigeration for X period of time in different batches, and then a full 24-hour run out at 22.5. It didn't do the higher temperature, but it certainly did do the sequential storage with good dosage ranges. So this is a good study as a baseline for OPAT. What they found, and if you look at the top table, that was purely looking at up to 7 days only refrigerated. From the 6 to 25 milligrams, and quite a lot of those dosages, if you look at the 3-day column at T equals 72 hours, 3 out of the 4 concentrations still had over 92% and above. So that's a great starting point for Meropenem, considering we know that we're probably not going to get this 7-day stability with elastomeric runouts after it, that whole golden standard we would like. But certainly, maybe we can order in batches of 2s and 3s or something like that, and have that option. And if you look down to the bottom table where we've got the run out phase, if you look at the T equals 72 hour one, that essentially is 48 hours within the fridge and then 24 hours run out after that. You've got the 92.5% for the first one, and then you've got 88% and 85%, and then 79% for the higher concentrations. So very promising results, but what this paper possibly could have done better, which I would love to have seen the numbers for, is if they had looked at a maximum deliverable dose or total dose administered equation for the 12, 20, and 25 milligram per mil solutions. They may have got in the high 80s or the 90% of the total dose administered ratio. So possibly could have had better data looking than what it actually looks like with that. I just don't like this 90% cutoff for the very last milliliter of solution. I think it makes a lot of drugs, or it can make data look worse than it really is. Next one we've got is a UK-based study where they designed Meropenem stability study around the yellow covered document, which some of you would probably be well aware of. What they did, though, is they did want to run it at higher temperatures, so they looked at 32 degrees, but they didn't have any pre-phase storage conditions, which is one of the things that I thought was one that they could have possibly added in, which would have made the evidence a bit more relevant. So we've got 6.25 to 25, the good range of diluents and buffers as well, which you can see on the next slide. We've got a heap of a range of buffers and things there, but unfortunately they found that pretty much all of them, in fact all of them, didn't make the 90% stability mark there. The promising parts about it, I guess, was they were just scouring for buffers that may have progressed the stability data that we have for Meropenem. And the 1% buffer, citrate buffer, you can see does look like it maintains a bit more stability than the other one. And also in the lower strength, similarly, it's slightly better as well. No analysis on whether that was significant or not, but it certainly makes you think that potentially the citrate buffer at 1% pH 6 may have had a bit of advantage there. Now, this study here is probably one of my favorite ones. This is a study done in Australia, in Western Australia it was, and it breaks down a lot of the parts of the evidence that I like to see. So this one here, they had 1 to 2% infusions. They had cooled or not cooled, refrigerated once they were made. They were refrigerated overnight and then allocated to be run out in normal conditions or in with an ice pack beside it. And then secondly, then they did some software modeling to see if it would maintain MIC, and then the part B was when they did a massive, quite a large retrospective review of 6 years of clinical patients' outcomes, which I think I guess at the end of the day, that's the most relevant part of all of this, is the outcomes of the patients that they've done this on. So we've got the evidence of the solutions and the stability. They've got cooled versus not cooled, and most of them they're only breaching this 90% by a little bit. And if you did the total dose administered for them all, you end up with some very good numbers over here. So if you can see the right column there, all of them meet the total dose administered of greater than 90%, except for the 2% uncooled. But what they did next, and this is the interesting part, is they then ran these things through some software and did some software modeling where they looked at does it maintain MICs. So the left side is the 1% uncooled, and the right percent is the 2% cooled data. And I would have liked to seen the 2% uncooled data, which ended up being an 85% total dose administered calculation, but I reckon that probably would have maintained the MIC anyway, concentrations above the MIC quite well anyway. So I think that part of the study was really well designed, and I like that they did the theoretical calculations as well. So the second part of the study was when they did a retrospective review of 6 years worth of administering meropenem infusers to patients. They had 50 patients over the 6 years, so which is a decent number to be evaluating. If you looked at the infections, that's the kind of infections you might be looking at. 40% of cases were polymicrobial, and almost half the patients had a second antibiotic. Now, if you look at the clearance rate, roughly 82% of patients were either cured or had improved, and we're looking at just shy of 20% of patients that had failed therapy. So their summation was that meropenem infusions are likely to deliver 95% of the maximal deliverable dose and maintain effective plasma concentrations throughout the dosing period. And they're basically saying that they're happy, it reflects favorable for using it. So this is a very strong paper for that sort of changing our opinion of meropenem's use in practice in OPAT. Now this last study is one of the studies that also looks purely at clinical evaluations. And this is something that we're moving a little bit more towards, rather than just the pure technical analysis of the drugs, but the clinical evaluations of what's happened. It didn't do any stability data, it purely looked at clinical outcomes for over a 3-year period. They had 34 patients that are over 35 episodes, similar sort of numbers of infections, a little bit more people had combined therapy. And it was fairly similar with the types of infections and things like that. What they did show was that if you look at the bottom line there, was that 23 patients out of the 32 did not experience any unplanned readmission, reoccurrence, or death. So this was a little bit less than the previous one, which is a little bit over 80% that had good clearance and success. This was down at 71%. So one of the questions that I guess we ask ourselves is, what is an acceptable level of clearance from a clinical evaluation point of view? This paper basically concluded that meropenem is an option to be used in OPAT, showing that 70% effectiveness, but there might be further studies should help support this. So let's break it down. Where does that leave us now? Still, if we look at the technical side of things, there's still no studies validating the gold standard of 7 days refrigerated plus the run out periods. But there is some studies showing 24 hours at certain temperatures after shorter periods of refrigeration. So we do have a bit of evidence for potentially smaller batches of 2s and 3s being ordered. We are now gaining more and more studies that are looking at clinical outcome data or NMIC data. So we've got, like, just with those 2 studies I presented, that's 15 over the last 15 years worth of clinical outcomes data and building. And the question we've got to ask ourselves is this part more relevant to OPAT than the stability studies themselves? And I guess the other point is Australia still lacks some solid guidelines, robust guidelines to govern how to do stability testing specific to OPAT, and then also choosing antibiotics specific to OPAT. So in my summation, I'd probably say that in normal temperatures, so not higher extreme temperatures above 30 degrees, I probably believe that we could be using OPAT for shorter periods, so possibly ordering batches of three days at a time. But I don't believe we have the full evidence to support it in warmer climates at the moment. So thank you very much for taking the time to listen to this talk, and I appreciate being welcomed along tonight to share my experiences. Thank you.